Okay, well, thank you for having me again today. This is a very broad topic, and there are multiple aspects to this. And honestly, a lot of the components of this science need separate lectures on their own. And I think, when I was just going through this, Dr. Mervat, I realized for students of cardiac electrophysiology, you might need to have dedicated sessions talking about things like activation mapping, entrainment mapping, so on and so forth. These are extremely important concepts in cardiac electrophysiology and actually deserve hammering down and working on very thoroughly. Um, when you talk about ventricular tachycardia, you will touch on that. And when you talk about things like atrial flutter, you will touch on that. But I think they do deserve their own space. So I tried to do, just a little bit of, just touching bases on those topics, but they're extensive. And there's not enough time to talk about all that. Um, Anyway, my disclosures seem like last time. We're going to try to review some definitions of what atypical flutter is, and we will talk about the necessary underlying substrate. Apologies for the spelling typo there. And then we're going to talk about the origin of left atrial flutter, what different circuits we have, what different sites of origin could be, and we're going to talk about how we map it, P-wave morphology, or EKG-based mapping, if you will. We're going to talk about that a little bit, and we're going to talk about some of the clinical outcomes, and we will also talk about some anatomic correlations. We're going to review some cases. And when we talk about, I'll just silence that. When we talk about atypical flutter, honestly, what comes into mind, what jumps at me immediately is the difficulty in mapping. Atypical flutter is a mapping dilemma. The problem is mapping. And so what is the definition? What is atypical flutter? What do we call atypical flutter? Atypical flutter is anything that is not dependent on the cavator-cuspid isthmus. Why? Because that was the first one that was discovered. A lot of effort went into defining the elements of the circuit in cavator-cuspid isthmus. Very diligent. People mapped this with very simple quadrupolar catheters back in the days. They didn't know all the concepts we know today, so for them it took a long time to figure out what cavator-cuspid isthmus reentry was, but that really was the basis for a lot of concepts that came on later in our current understanding of atrial flutter. But because that one was discovered first, it was called typical flutter. And anything that was not conforming to that was called atypical flutter. Obviously, mapping other things was a lot more complex, less accessible, needed more advanced mapping technology and catheters, and therefore, it was considered just the other stuff, the atypical stuff. But there are just other flutters like cavator-cuspid isthmus. They don't use that for their circuit. Generally speaking, they're complex circuits. They use anatomic barriers to exist. And we are seeing more and more of those with increase in complex left atrial ablations. People are a lot more aggressive with ablating extensively in the left atrium, and that is a self-fulfilling prophecy. In other words, once you start doing it, it just keeps happening. Pharmacologic management for atypical flutter is really limited. Antiarrhythmic drugs rarely work. Class 1C antiarrhythmic drugs, I absolutely do not recommend using them in this situation. Some people do. I absolutely do not recommend it. Do not use Class 1C antiarrhythmic drugs in the setting of, I would say, generally atrial flutter, any atrial flutter, but especially atypical flutters, people, prior ablation and whatnot. It's been used, but every once in a while, maybe 5 out of 100 patients, you're going to precipitate slower flutters that conduct one-to-one, which is exactly the next bullet point. And these can be very dangerous. You can cause syncope. And you would have to pair them with good doses of AV node blockers. And that would be then risk for profound bradycardia, increase the need for pacemaker implant, and so on and so forth. Atypical flutters that are either, in my mind, clinically tolerated or can be treated with a small dose of beta blockers or calcium channel blockers or whatever dose works for rate control. And if none of that works, or if the patient is a candidate for a more aggressive ablation strategy, then this is ablation, ablation, ablation. Now, regardless of what we do with those, the risk of recurrence is high, especially if we do not address other potential substrate at the time of ablation. But this is a complex clinical syndrome. Now, what makes them happen? We talked about anatomic barriers, and those anatomic barriers can be natural or man-made. Man-made barriers are more common, and those include incisional flutters. So when surgeons open the right atrium to gain access into the interatrial septum, for example, to repair an ASD or to do a mitral valve replacement, or you get invariably with any open heart surgery, if you will, they cannulate the right atrium, and the right atrial cannulation essentially leaves a scar. If you're dealing with a bigger intervention, like a valve or something of that nature, then they do usually a long incision that extends from the SVC to the IVC. They've modified that over the years, the surgeons, and trying to avoid doing these complete incisions. But those incisions, in some patients, for unknown reasons, years later, cause what we call incisional flutter, and this is a very distinct syndrome. There is obviously the situation where there is any prior ablation done in the atrium, right or left, most likely left, being surgical or catheter-based. We used to call a large entity of these atypical flutters idiopathic atrial flutters. They really are not idiopathic in my mind. Arrhythmogenic cardiomyopathy is something that we're starting to understand a lot more than we used to. We used to call these idiopathic. Their patients have atrial flutters and scar for no reason. They do have a good reason, and its genetic basis could be viral infection, et cetera, et cetera. But arrhythmogenic cardiomyopathy, a large part of the spectrum of these disorders actually involves atrial myopathy. These patients present with atrial fibrillation, atrial flutters, typical or atypical, sinus node dysfunction, enlargement of the atria, and there is a very nice document that was produced by, I believe, the Heart Rhythm Society, and it could have been the American College of Cardiology, the ACC, and it was essentially focused on arrhythmogenic cardiomyopathies. I recommend reading it. It was a consensus statement and a guideline document released, I want to say, at least 5-6 years ago. And it was terrific, absolutely terrific, in terms of thorough description of all of these disorders. They're extremely relevant to atrial arrhythmia, not just VT. And I recommend to anybody studying the field of cardiac electrophysiology to try to read them. It will change the way you approach these disorders. The right atrial free wall can be a site of origin. The perimitral reentry syndrome, we call it mitral flutter. They can be roof dependent. They can come from the septum. They could involve the right pulmonary veins, left pulmonary veins. And last but not least, the fun part is when you have multiple loops, multiple forms of atrial flutter going on at the same time. Well, how can that happen? We have one cycle length. How can that happen? Well, essentially what you have is you have multiple loops. They could be going at the same cycle length, or they could be entraining each other. In other words, one of them is faster, and that's the one that sets the tone as far as the tachycardia cycle length. The other one is essentially being entrained by the form of tachycardia that is shown on the EKG. And usually you ablate one, you get another one. Without an interruption of the tachycardia, the cycle length changes, activation changes, maybe, maybe not. But the tachycardia doesn't stop and the cycle length changes, and you don't think it's because of a gap in a line or something of that nature. Now, very important and the most relevant syndrome of all for all interventional cardiac electrophysiologists is the post-AF ablation atypical flutter. And so that is something we cause. This is man-made, doctor-made flutter. For the most part, some of it is, there was substrate. We did something in the atrium. We didn't address that substrate because it's hard to find it, hard to know what to do about it. And we get out and then they have atrial flutter down the road. Now, if you, the approach to the AF ablation does have some bearing on that outcome. So it turns out the more ablation we do in the atrium, the more likely it is that we have these types of flutters. So if you only did a PVI, the incidence is about 4%. 4% of those patients will have atypical flutters. If we did a wider ablation, which, there is a very specific paper that described that, wider ablation meaning a wider intra-ablation, it goes up to 30% of patients can have atypical flutter, so it goes up that incidence. If you, look at post-Maze patients, so surgical ablation patients, especially the ones who had full Maze lesion set, 15% of those patients end up with atrial flutter. I actually think it's higher than that, but that's what's documented in the literature. So the more ablation we do, the more problems we cause if we do not block lines. I'm going to repeat this. We do not block lines. If you're going to be intervening on anything in human tissue, you better block that line. We're talking about the atria. It's harder to do that in the ventricle. It might not always be necessary, but in the atrium, it is actually extremely necessary. If you start something, you have to finish it. Let's talk about the anatomic barriers that we could be dealing with in the left atrium, just more basic anatomy for, those who are still learning this subject. This is from McAlpine's Atlas of Anatomy. And, I'm going to focus on this view first, top left. You can see the right pulmonary veins, left pulmonary veins. Right pulmonary veins are very adjacent to the superior vena cava. The inferior vena cava is that vessel way down. The pulmonary veins, right or left, act as a barrier. They are not necessarily fibrous tissue, but the cardiac conductive tissue or cardiac myocytes that are actually able to conduct electric wavefronts end in the pulmonary veins. So it essentially acts as an anatomic barrier to conduction. The veins on both sides form that, but also the mitral annulus. So if you look bottom left, the mitral annulus is a little different because the atrial tissue terminates into fibrous tissue. The annulus is fibrous tissue. Ventricular tissue attaches to the annulus, but there should be no connection between the atrium and the ventricle from an electric perspective unless you have a bypass tract. It's a different issue. But the annulus, by definition, being fibrous tissue, acts as a barrier of conduction. And barriers of conduction are very important for wavefronts to have a definite or definitive pathway. Otherwise, they become diffuse conduction, kind of like normal conduction. So when you have diffuse conduction, you don't really have a high chance of forming reentry. Whereas if you have a definite pathway, protected corridors, you can then take advantage of slow conduction to create reentry. While we're talking about anatomy, there are a few things I would like to note here. And they do affect the work you do in the left atrium, especially when you're dealing with those atypical flutters. The interatrial bundle, what we call today Buckman's bundle. Buckman's bundle comes from the right atrium, from the vicinity of the SVC-RA junction, essentially connecting to the crista terminalis sinus node, the right atrial appendage, and traverses the roof or the anterior roof of the left atrium, going into the left atrial appendage. Its purpose and its function is to synchronize atrial contraction between the two appendages, which are the ones responsible for the majority of the atrial output or atrial contractility. And so that poses some challenge when we work on the anterior surface of the left atrium, especially as we head towards the roof, because we got bundles of tissue, bundles of muscle that conduct very fast and at the same time are more poised to be on the epicardial surface, and it's also thick. And so that poses some challenges. Another important consideration that I thought was really worthy of noting, as Buckman's bundle traverses into the left atrial appendage, now I'm working on this figure out there, top right, and right behind the aortic root, there is an area in the left atrium that is not covered by muscle bundles. That area is called the unprotected area of the left atrium. It is unprotected because there's not a whole lot of muscle coating around it. Why is that important? If you're ablating here, especially if you use an RF, be very careful, because a stem pop in this area or excessive contact force as you are working on the anterior surface of the left atrium, which is an area that we frequently have to work on. Be very careful with contact in this area. The only time I've had a perforation caused by ablation in ablation for atrial fibrillation, it was actually it was actually an AF ablation. It was an older lady, was in this area. Okay, the surgeons know exactly how to get there. Problem is, it's not necessarily that easy to to get to it. You have to get behind the aortic root. And so very little muscle coat, and at the same time high risk for perforation. And if you perforated it, it would actually be something that might have to go to the OR. I'm going to skip slides because I know I have another transillumination slide or view of this. So you can see Buckman's bundle up here. Okay, and under Buckman's bundle, they have a light essentially in the left atrium, so transillumination view there or slide, and you can see how thin the coating is around that area. It's called the unprotected area of the left atrial anterior wall. Anyway, go back to what we're talking about today. How do we know the site of origin and be precise in eliminating the rhythm? Well, activation mapping and entrainment mapping are things that are frequently talked about. I want you to also think along the basics of electrophysiology, and we want to be the best in the field, and we want to learn the nuances of electrophysiology, and not just the commercial aspect of how can we get the case done quickly. P-wave morphology is extremely important. We're going to talk about activation mapping a little bit, since this is the most commonly used approach. This is sort of a reflex to start doing an activation map when we're faced with atypical flutter. What is an activation map? It's an accurate electric timing map. And this is something that can make or break your case. The convention is to split the window. You take the cycle length, you split it in half. So let's say cycle length is 250 milliseconds. You split your window of reference on the mapping system, 125 milliseconds before your reference and 125 milliseconds after your reference, and you start annotating signals along that window of interest. Activation mapping can be tricky if you have a focal atrial tachycardia. And that will bring us to another point that is very crucial. But if you think you're mapping a focal atrial tachycardia, if you think you're mapping an automatic non-reentrant rhythm, and that's very important to know, then you need to adjust that window differently. You need to be looking at what happens right before the P wave. That's what matters. It's not so much the entire atrium. You want to see what happens right before the P wave. So adjusting your window can make or break your activation map. Another aspect to activation mapping that is extremely crucial, and that is not something that we can change. It's not a technique thing. This is a technology thing. And the technology thing is annotation. Where do you annotate the signal? Do you take it at the beginning of the signal, in the middle of the signal, at the highest dV by dt? Do you annotate the bipolar signal? Do you annotate a unipolar signal? How do you get rid of far field? So on and so forth. There are a lot of details to this, and that's why I said this probably needs to be addressed in a separate talk. This is a very, very important topic. The better approach, the more modern approach when you adjust your window anymore is to adjust your window to 40 milliseconds. I'm sorry, this says seconds, it's milliseconds before the P wave. And to use that, be it, re-entry or I'm sorry, can you hear me? I'm having issues with the.
Yes, we are
You
heard
can hear me?
you.
Okay.
We hear you.
I just got a message that there is an issue with the internet or something. So anyway, please let me know if you lose me, send me a message or something. So
We hear you very clearly.
you can hear me? Okay, good. So the better way to do it is to set up your window to start 40 milliseconds before the P wave onset. And that begs the question, well, where does the P wave start? That can be sometimes hard to define, especially in atrial flutter, because by definition, what's an atrial flutter is something where there is not an isoelectric segment. That's sort of the definition of flutter versus atrial tachycardia, which I actually think that these sort of classifications are not very helpful because they do overlap. This paper I put up there for additional reading. It's an excellent paper and something that provokes thought. Not everybody does it that way because they can't really tell where the P wave starts, but if you can tell where the P wave starts, I would definitely follow the approach defined in this paper. Now, things that can be very tricky when you do activation mapping and you're trying to figure out if you're dealing with a macro reentry or you're dealing with a focal rhythm is essentially the situation where you had prior ablation and you have a line of block, and then you have a focal rhythm. The focal rhythm, if it is arising from an area that is near a line of block, can look like macro reentry. Why? Because the impulse has to travel throughout the entire atrium to get to the other side. We'll have better examples later. I just wanted to throw that out there. How do we tell and how do you use those? Well, for doing activation mapping, late activation in focal arrhythmia, late activation will be far away from the earliest activation. Okay, so in a focal rhythm, there's an early spot, and then the rest of the atrium becomes later and later and later as you go far away from these origins. Whereas if it's macro reentry, obviously late and early are close. Why? Because it's a circuit. And so as you become, it's a continuous circuit. It's a circle, essentially. As you get to very late, well, then you're going to become very early right away, not far away from it. And some people say, well, we got early meets late. So early and late are sort of in the same in the same part of the atrium. So that's helpful. Now, again, if you have a line of block, that might be thrown out of the window. So the amount of the tachycardia cycle length you account for in a particular chamber, in the site of origin chamber, if you have a focal rhythm, you will find that a lot of the tachycardia cycle length is not accounted for because it's not reentry. We don't have part of tissue or parts of the atrial tissue accounting for every second or every millisecond of activation. And so the with macro, I'm sorry, I keep getting error messages about sharing video. I'm not sure what the this is stall. Not now. Okay, you guys can hear me, right? Okay.
Yes, we are hearing you.
You can hear me, right? Okay, alhamdulillah. Okay. With macro reentry, you should be able to account for the entire cycle length, almost all of it. Up to 25% can be unaccounted for. And you can say, well, we're in the right chamber. 25%, maybe 30%. But we would like to see something better than that. Generally speaking, you can get the entire cycle length in the atrium where the site of origin is. And that's something that defines macro reentry versus focal origin. We do mapping to know where to ablate. And since we are looking for that target, well, how do we define that? If we're looking for a focal rhythm, we're just looking where the earliest activation is. And that earliest activation, hopefully we set our window right. Hopefully our window does not truncate the P wave. Hopefully our window allows for ample duration before the onset of the P wave. Then the target then becomes the earliest activation. Whereas if we're looking for macro reentry, now if you adjust your window properly to actually start right before the onset of the P wave, or 40 milliseconds before the onset of the P wave, like we mentioned, then ablating the early part is sort of, or the earliest annotated signals is theoretically at least directing you towards which part of the circuit now? The exit, right? So that's okay. That should work. But I want you to think about it from a mechanistic perspective. We don't necessarily want to be looking for the map to go like, well, okay, give me a color so I can go. Well, the color is not what matters. What matters is understanding where the circuit is. And to understand where the circuit is, in macro reentry, a circuit is dependent on slow conduction. You're looking for slow conduction. That's what you're looking for. So the question number one, is it focal or macro reentry? Well, I'm saying it's macro reentry. Why? Because I see late and early next to each other. A. B. I see most of the tachycardia cycle length, almost all of it, if not all of it, in the chamber I'm in. So that tells me, hey, I'm probably dealing with a macro reentry. But what is my target then? My target is the area of slow conduction. Okay? Doesn't matter if it's annotated early or not. If you set your windows properly, the earliest activation should lead you to that zone. But that zone can sometimes be a little bit superior, a little bit inferior, a little bit more septal, a little bit more lateral. Okay, so there are better ways to sort of look at that, looking at propagation maps, trying to understand where conduction becomes very slow. Why? Because this is the most vulnerable part of the circuit. This is what you need to target. This is a case I did. I'm going to talk about it a little bit more, but you can see here early and late, they're all in the same spot. It looks like we got the entire cycle length. I don't have the spectrum there, but it was the entire cycle length of the tachycardia. I will present this case later on, but I wanted to show it to you now just to show some of what we're talking about. But this case is worthy of additional mention later on, so we'll get to that at the end of the presentation. I don't want us to be focused on industry data, on industry direction to figure out what to do. We have to still, we're electrophysiologists, we have to still be able to read P waves. Sometimes that is the only clue you have. Sometimes the tachycardia is actually intermittent, non-sustained, sometimes dissociates into atrial fibrillation very quickly, and you cannot do any mapping at all. The only thing you have is looking at the P waves. You could also look at the P waves while your lab staff are getting the case ready, and the general rule of thumb, be it PVCs, be it atrial arrhythmias, be it ventricular tachycardia, be it anything, you want to know where you're going to ablate and where you're going to map. Well, map first and then ablate before you start. Now, that gives you a little bit of bias, but at the same time, you cannot, in every case, every time you handle any rhythm, ablate or map the entire heart before you figure out where to ablate. You have to be focused. You got to know where you're going, and you have to minimize that amount of time, the diagnostic part of the procedure. Minimize it not by being sloppy, not by cutting corners, but by using all the information that is available to you. P-wave morphology is extremely important. This is a paper from 2011. It describes that approach. I put it out there for additional reading for those who want to read it. You have to understand the principles of the EKG, and this is really what sets us apart as electrophysiologists from general cardiologists. We understand EKG on a different level, and we have to read EKGs from that perspective. And so if you looked at V1, just quickly going through this algorithm, you don't have to memorize it. I don't memorize any of this. Certain patterns stick in your head. You can print it, keep it in the lab. Just, even the best electrophysiologists out there will have these things hanging in the lab on the walls. Put them out there. No shame in reviewing. There's no reason to memorize things like that. But the rules are, V1 and the precordial leads will tell you roughly what part of the atrium you're in. Are you very anterior or very posterior? And that is true for VT, that's true for atrial arrhythmia. So the precordial leads will help you kind of determine how anterior, how posterior you are in the atria. And then the inferior leads tell you how inferior or superior you are in the atria. And then lateral leads, 1 and AVL, tell you how lateral or left you are versus right. And then you make any possible number of combinations of all of these factors, and then you get a very characteristic pattern for every single one of those sites of origin. Now, this is actually developed, this particular algorithm is for focal atrial tachycardia. Now, I thought it's still relevant for this because the idea here is we cannot tell from an EKG where the circuit is, but we cannot tell where the zone of slow conduction is, but we can tell where the exit is. And that's really the same, be it atrial flutter or atrial tachycardia, it is the same. We're mapping an exit. Same for VT. When we look at a 12-lead EKG, trying to figure out from the EKG where the site of origin is, what we're doing is we're mapping the exit. We don't know where the tachycardia isthmus is. And so these principles are important. You look at V1, and if V1 is negative and then turns into positive, generally speaking, this is something just in your head, you see a transition. So we call that precordial transition. In an atrial arrhythmia, when you see a precordial transition, in other words, it was negative and it became positive, or in V1 was sort of biphasic, positive, negative, and then it became positive, then you're usually dealing with something that is coming from the right atrium. Okay, and if it turns positive in the rest of the precordial leads, then it's probably cavo-tricuspid isthmus dependent. So it was negative, turned positive, most likely cavo-tricuspid isthmus dependent. If it is positive, negative, like biphasic in V1, then also that's very suggestive of cavo-tricuspid isthmus reentry. If it is negative in the inferior leads and does not have this sort of transition, so it's sort of negative in V1 and 2 and 3 and 4. So a lot of negativity throughout the precordial leads, and then also negative in the inferior leads. Then it usually points to something around the tricuspid annulus. It could also be on the right atrial appendage if the heart is laying a certain way. Now, if you have a negative, positive, isoelectric positive look in V1, and then you see AVL, being very negative, that usually points to something coming from the left atrium, and that is usually the superior mitral annulus. If AVL is negative, if AVL is positive, it could be coming from the ostium of the coronary sinus. If you are dealing with something that is isoelectric in V1, and sort of has very, very tiny P waves, almost isoelectric throughout all the precordial leads, doesn't have a whole lot of voltage in the precordial leads. Very suspicious, especially with a very narrow P wave. Very suspicious for something arising from the interatrial septum and around the AV node. And this is true for a lot of arrhythmias. Anytime you see a P wave that is very narrow P wave, suspect origin from the septum. Now, the left atrium is a little bit probably easier to understand. when you start walking, when you start moving back towards the posterior wall of the left atrium. So you get closer to the pulmonary veins, the very posterior precordial leads are going to be more positive. So V1 through V6, you're going to see a lot more positivity there. If now, and what you need then to differentiate is things arising from the left pulmonary veins, things arising from the coronary sinus, and coronary sinus is going to be negative in all the inferior leads. If you're coming from the coronary sinus towards left atrium, it's going to be positive in all the inferior leads. I mean, negative in all the inferior leads. If it is positive in the inferior leads, and at the same time positive in the precordial leads, then you're probably looking at something coming from something that is lateral, posterior, and superior. So we're talking about the left pulmonary veins or the left atrial appendage. This is a pattern that we probably need to remember and remember very well. And the reason is there's a lot of talk now about left atrial appendage triggers, left atrial appendage tachycardias, isolating the left atrial appendage. You got to be able to identify that pattern of left atrial appendage P wave morphology. And then, the right pulmonary veins are going to give you something that is, bifid in lead 2 or V1, and at the same time, or I'm sorry, not bifid in lead 2 or V1, and the P wave is going to be positive or negative from the right pulmonary veins, depending on which pulmonary vein you're looking at. Superior vein, inferior vein, obviously give you two different P wave morphologies. And, I don't necessarily feel like you have to memorize any of that. Certain patterns you have to memorize. You have to remember what that looks like. Typical flutter, the way it looks clockwise, counterclockwise, that's also a distinction. And then apply that to the right atrial rhythms. And then the left atrium, you got to understand what the EKG will look like if you're very posterior towards the posterior wall and the pulmonary veins versus more anterior in the left atrial appendage. Some examples. Things arising from the ostium of the coronary sinus. You see these P waves? Anytime you see these very deep P waves in the inferior leads, you always just think of the coronary sinus. Go to the ostium of the coronary sinus, see what's going on there. This is not just relevant to you. This is to atrial tachycardia or atrial flutter. This is very relevant to a lot of other things. For example, PGRT, other forms of AVNRT where the exit, the atrial exit or the retrograde limb of the tachycardia is in the mouth of the coronary sinus, will give you something that looks like that. And notice here the transition in the precordial leads from slight isoelectric to negative, and the characteristic look of the P waves, and then it's positive in lead 1. So it's telling you this is not a lateral site of origin. This is something that is coming from a more medial, more septal, more right atrial site of origin. Inferior tricuspid annulus is going to give you something that is similar, but look at V1, okay? So when you get to the tricuspid annulus, you're more anterior to the coronary sinus. And because you're more anterior to the coronary sinus, you become more negative in all the precordial leads, all of them, including V1 now. Subtle differences, very important, okay? And then you look at AVR, because you are directed straight at AVR here will be positive, inferior leads will be negative. But notice how this P wave is a little broader than this P wave, okay? This P wave is broader because it's not septal. It's not a septal structure like the coronary sinus. Coronary sinus has access to both atria, quick access to both atria. So this is what you see with, something coming from the inferior aspect of the tricuspid annulus. And by the way, understanding these principles helps you so much in VT. EP is all connected. It's all a connected mesh. You have to understand the principles, and then you apply it to anything, and it works most of the time. Now, look at this one now. This is inferiorly directed. Okay, and I didn't sit down and memorize all of these. I'm just going through it with you guys because I want you to think through it just the way I think through it too. You can see two things. It's inferiorly directed. That's number 1. 2 and 3 are positive. And at the same time, you see a transition. So negative, negative, flat, positive, positive, positive. Transitions in the precordial leads, generally speaking, imply right atrium, generally speaking. This is sort of, you see a transition with typical flutter. it usually is either early or mid-precordial. But here you see this inferiorly directed axis, and that inferiorly directed axis tells you it's a right atrial structure. It's high up in the atrium. It could be coming from the SVC. It could be coming from the right atrial appendage, which is what that case was in that particular paper. And then here's another pattern of something that is also important to recognize. So the crista terminalis, which is essentially very close to what the sinus node is, right? This is almost where sinus rhythm comes from. And so crista terminalis P waves have, generally speaking, the same characteristics of sinus P waves, but they're different and not exactly the same. Why? Because they can be higher up in the crista, lower, mid, it depends where in the crista they are. But look, this is really what's very characteristic about this. 2, 3, leads 2 and 3. The P waves in lead 2 are usually more prominent than the ones in lead 3. As you come down the crista, you could even have negative P waves in 3, still positive in 2. Okay, partially because lead 2 is looking at more towards the left compared to lead 3. So as you come down the crista terminalis, you start becoming flat and then even negative in lead 3. This is a very characteristic pattern. Because we're moving away from AVR, essentially the crista is like the far right part of the heart at that point, we're going to become negative in AVR. That also applies to the right atrial appendage. And so, but notice how, kind of sharp, good P wave amplitude, whatnot, you get from the crista terminalis. And if it's coming from high up in the crista terminalis, it really looks just like sinus P waves. This can be very deceiving. And, this brings me to a concept I didn't necessarily address very much at the beginning of the talk. What is an atrial tachycardia? What's an atrial flutter? In my mind, those are EKG terms. They were developed early on in the process when all we had was an EKG to try to figure out what those rhythms are. And when there is an isoelectric interval, which you can see here, so you can see a P wave and another P wave. And between, let me see if I cannot zoom on that. Anyway, there's a P wave and a P wave, and between them is an isoelectric segment. Conventionally, you would call that atrial tachycardia, which then translates into our mind, into our brains understand that as focal. It's a focal rhythm. Okay? That's not always true. That's not correct. So I don't want to think about it that way. Okay? Now, if you were reading an EKG and that's all you had, I would call this an atrial tachycardia. If I was reading that EKG on the right, I would call that an atrial flutter. Why? There's not an isoelectric segment. The P wave goes up and down and up and down and up and down all the time. Why? Part of the atrium is depolarizing at all times. And that's what gives you that. But that really doesn't tell you anything about the site of origin. Most of the time, it implies that this is a macro reentry and this is a focal rhythm. Guess what? Wrong. There are always exceptions in EP. In this particular case, this was macro reentry arising from the left atrium, and this was a focal rhythm arising from the pulmonary veins. Why does this look like this and this look like that? Well, this one was facing large amounts of scar in the left atrium. And so by the time that slow conduction came out of scar, okay, there was an isoelectric segment. There was activation in the scar, but it's very small, very tiny amplitude to the point where you can't see it on the surface. So it gives you something that looks like an isoelectric or a very wide diastolic corridor. Whereas in this rhythm, which is actually focal, what happened here is this patient had prior ablation and there were lines of block. And because there were lines of block close to the site of origin, what happened is the impulse had to travel all around the atrium to activate the entire atrium. And so we ended up with something that looks like a flutter. There's continuous activation, continuous activation of a good mass of tissue, whereas this continuous activation of a very tiny mass of tissue. You can see this one, but you can't see this one. So tachycardia versus flutter, what we're talking about today is atrial flutter, but it really is, the same thing. They're all continuous syndrome. and you don't know what you're getting yourself into. Now, if this is a healthy person who only has that and has never had an ablation before, common things are common. It's probably an atrial tachycardia arising from the coronary sinus ostium or arising from the crista terminalis or someone that had multiple ablations before. Well, most likely it's re-entry, most likely. But don't pin yourself to a particular idea before you get in. Get in, do your study, understand what's going on, but it's good to know where to look. It's good to know where to look. Are you dealing with the right atrial rhythm? Are you dealing with the left atrial rhythm? That is very important to know up front. Again, more P wave morphology, right superior pulmonary vein, superior mitral annulus with their characteristics. I'm going to go through it with you guys just like I'm thinking about it. Right superior pulmonary vein. Is that an anterior structure, a posterior structure in the atrium? It's a very posterior structure. Look at the transition. There's no transition. It's positive. V1 through V6, all of it is positive. Okay? When you see that, you know you're coming from somewhere near the posterior wall. Something has to do with the roof. Something has to do with the left veins. This is far away from the precordial leads, and that's why it's positive throughout. Now, are you positive or negative in the inferior leads? You're coming from something high up. It's positive. Sorry. And then, lead one is positive. So you're not coming from the left pulmonary veins. You're coming from the right pulmonary veins. That's the only thing that is in the left atrium. Is very posterior, very high, and septal, not lateral. So that's the right suprapulmonary vein. That's how you need to think about the P waves, because none of these rules apply to every patient. Every patient is different. You have to think through the process and be able to modify it. The mitral annulus, well, it's high up in the atrium. It's going to be inferiorly directed. We're sort of flat in lead one because we're a lot more lateral, right? And then we're also more anterior compared to where the veins are. So we're going to be positive in V1, but we're going to start seeing a hint of reduction in P wave amplitude as we go through the precordial leads. Mitral flutter, if it is counterclockwise mitral flutter, kind of looks like that. The left atrial appendage. Don't forget that. There's a lot of talk about it. A lot of experts advocate isolation of the left atrial appendage in certain situations. So if you see triggers coming from the left atrial appendage, you got to be able to identify them. And that is the characteristic look. Very narrow P wave. It has, it's positive in the inferior leads. It's negative in lead one. In the precordial leads, we see very low P wave amplitude. It starts probably positive and starts becoming very, very, very low amplitude. So we're not posterior, we're anterior, we're lateral, and we're directed, and we're high up. That's what the left atrial appendage. The septum. Now, look at these P waves. We haven't seen anything that looks narrower than this. This is so narrow. Look at these P waves. So tiny, so tiny. You know what it reminds you of? It reminds you of the P waves of AV-NRT, typical AV-NRT. Why? Because that's where the exit site is. It's embedded in the septum. They're very tiny, tiny P waves. And so it's almost like even hard to tell any polarity on this. But you can see, if you look very hard, you can see it's negative V1, negative V2 turns positive. What did we say? This sounds like right atrium. And it's very narrow, very, very narrow. It's probably septal. The non-coronary cusp, and that is something you will experience every once in a while. There's quite a bit of those. I think a lot of what we call non-coronary cusp atrial tachycardias are honestly just left atrial tachycardias arising from the left atrial side of the septum behind the non-coronary cusp. And that makes sense because the non-coronary cusp itself is fibrous tissue. There's no atrial or ventricular tissue inside the cusp itself. Why do we ablate them there? Because we can then essentially have access to that part of the septum. So most of these, honestly, in my opinion, you can go to the left atrium and you will have a much, much better lock and easier way to map them. Sometimes you have to approach it from both sides, from the atrial side and from the non-coronary cusp side, especially if it is something that is intramural, if there's a lot of scar and whatnot. Obviously here, you got to be careful around the conduction system. If it is in the non-coronary cusp, It is so much better to do it there than to try to do it from the, or to approach it there and than to try to do it from the right atrial side of that part of the septum, because then the risk of heart block becomes a lot higher, and you probably will not be able to get to tachycardia. Again, we look here at the P-wave morphology, and you can see something that looks very negative, kind of maybe turns positive a little late in the precordium, maybe not. Negative in the inferior leads, and at the same time, sort of slightly positive in lead one. Okay. Now, I thought focal atrial tachycardia is very helpful to try to understand sort of these cardinal principles of how to use the EKG to tell you where an arrhythmia is coming from. These are P waves in patients who've had ablation in the right atrium. They had incisional flutters because of that prior incision in the left atrium. We talk in the right atrium, sorry, surgical. And you can see here again, we see the transition. Look, negative in V1, 2 starts becoming positive in 3. When we see that, we think right atrium. And then we see positivity in the inferior leads. So we're coming from something high up. We see ourselves positive in lead 1. And so that is sort of an exit in the crista terminalis, right? And if this is based on a focal rhythm, then that's a focal atrial tachycardia arising from the crista terminalis. If it is a flutter, then, if somebody gives you that, scenario, incisional flutter, somebody has had an incision in the left atrium, in the right atrium prior surgery, then that's what it is. But again, the EKG tells you how to fit it into the clinical context. This one here is also similar to that, but notice how negative we are in the inferior leads, and it depends where that exit is. So if that exit is really low, if that exit is really anterior, you can have a variation in that P-wave morphology. All right. Other P-wave morphologies, fun things to look at. The roof, left atrial roof, for example. You can see we're positive in V1, 2, 3, 4, 5. Maybe V6 would become a little negative, but when we see this sort of concordance in the precordial leads, we think something posterior in the left atrium. We look at lead 1, and you see how lead 1 is actually sort of negative or flat. So that immediately tells us it's not the right, it's something around the left side of that posterior wall. It could be exiting high up, it could be exiting a little low under the left pulmonary veins. In this case, it's exiting below the left pulmonary veins, I would say. I don't have the mapping on this case, but again, just showing you what that would look like if it were arising from the superior roof. And again, this is just depending on the direction it's spinning. Now, it doesn't mean it's not dependent on the roof. It's dependent on the roof, some slow conduction around the roof, and it spins around the left pulmonary veins. And so, again, you gotta just look at it. Don't fit yourself in a particular mold. Here's another one. Let's look at it. This is V1, 2, 3, 4, 5, 6. Positive, positive, flat, 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 flat. And or slightly maybe positive or very flat here, then you're looking at probably something coming from the left atrium. Why is it flat in the rest of the precordial leads? Well, it's not that posterior, right? It's not that posterior. It's a little bit more anterior. Okay, so what's more anterior in the left atrium? Well, the mitral annulus is, the appendage is. Okay, well, how are we doing in the inferior leads? We're a little positive in the inferior leads, not positive enough to call it left atrial appendage. That's a little higher. And at the same time, we're flat. The left atrial appendage would be very negative in the lateral leads. So that makes me think of mitral flutter. Now, mitral flutter comes in 2 flavors. We will talk about it in a second, but we think of typical flutter, when it's negative in the inferior leads, we call it counterclockwise mitral flutter or CTI flutter. When it is positive in the inferior leads, we call it clockwise CTI flutter. Now, mitral flutter is the exact opposite of that. So mitral flutter, if it is positive in the inferior leads, it's counterclockwise. If it is negative in the inferior leads, it is clockwise. This looks like counterclockwise mitral flutter. They're just opposite, CTI and mitral. Okay. P-wave can be a very dry subject, but actually I think it's a lot of fun, and you need to play with it. And you could play with it in a lot of ways. You don't necessarily have to do a million cases to understand it. While you're in the left atrium, just take your ablation catheter and map around the mitral annulus. Map at the left atrial, just pace, I'm sorry. Pace around the mitral annulus, pace around the left atrial appendage, pace on the posterior wall, pace by the right veins, and just look. You don't have to do it in the middle of the case. Just save them. At the end of the case, sit down and try to understand it. And then do it in a lot of patients. Frank Marshalinsky I trained with, and he would just do this pacing, and he would compare them, and he came up with his own charts. They're really amazing. Very, very detailed. But he looks at the general characteristics. Not in every patient is going to have something, a little variation, but he looks at the general characteristics, and he knows exactly where he's pacing from, and that's the beauty of it. Pace at low output, and learn. And we need to approach EP from that perspective. We need to learn. We don't want to be told what to do. We want to define, and we want to write, and we want to innovate. Is very important. All right, entrainment. We don't have time to talk about entrainment in detail today, but I could not sort of not mention some of the principles of entrainment. But this is really worthy of at least an entire lecture, if not more. But entrainment, generally speaking, implies resetting with fusion. We have a tachycardia that we're able to reset, and we're able to reset it with fusion. And that means macro reentry. So that's what entrainment means. You cannot entrain a focal rhythm. It's not called entrainment. It's called overdrive pacing at that point. When you say entrainment, you're already telling the audience that you are dealing with a reentrant rhythm. It's very important when you're writing a paper or you're making a presentation. Anytime you say entrainment is not overdrive pace. You can overdrive pace anything, but you can only entrain macro reentry. Okay, so you have to define macro reentry. And to define macro reentry, you have to have a rhythm that you can reset with fusion. Now, fusion can be manifest, can be concealed. Fusion can be fixed, can be progressive. What does that mean? There's a lot of details to that. You need to see a lot of examples. You need to learn it. You need to use it. These are the principles of EP. If you don't understand this, you'll never understand EP. Trying to show you some of these. I stole this from John Miller from the board review. He actually does a really good job of, just doing this work with PowerPoint, where he crops P-wave, atrial activation patterns, uses different colors and overlays them to show you atrial fusion. And fusion essentially means that you have a tachycardia. Tachycardia has a pattern. The pattern is right here. You can see it on the HIS catheter, for example. These are the atrial electrograms. On the halo catheter, these are the atrial electrograms. In the coronary sinus, these are the atrial electrograms. On the ablation catheter, these are the atrial electrograms. This particular arrangement is essentially a P-wave morphology of a different type. This is something that looks like a P-wave. It is not a P-wave. It is an interatrial signature for a particular pattern of propagation. This is what that looks like, okay? If I alter that by pacing, then I fused. I fused what? I fused what I changed in the atrium based on pacing to what the tachycardia was making the atrium do based on its own propagation. So I can fuse my influence and the tachycardia's influence. If I can fuse and reset, not terminate the tachycardia, I can reset it, then I am dealing with a macro reentrant rhythm. How does he do that? He usually delivers a single extra stimulus. He times it right in the middle of the P wave. So you have to sit down, measure what you're triggering from, and then you measure the interval from your trigger to where you want your stimulus to land, 200 milliseconds, 150 milliseconds. He would set the extra stimulus to be delivered in that particular area, and he can, or inside the P wave, and he can then move the stimulus 10 milliseconds pre, post, whatnot, to see if he can usually a little bit earlier, until he can show that he's able to reset and fuse. Resetting, how to prove resetting and all that, these are things that will need to be described, need to be discussed in a different talk. It's a very extensive topic. Principles that you have to understand. Every electrophysiologist needs to know this by heart. So what we're seeing here is this is the tachycardia, and I'm sorry, he's pacing here and trying to entrain the tachycardia. And what we're trying to show you here is while we're pacing, okay, the atrial activation kind of looks very similar to what we see during the tachycardia. So if you look at the CS, kind of looks the same. If you look at the halo catheter, looks the same. The relationship between these catheters looks the same. The post-pacing interval is equivalent to the tachycardia cycle length, 310 milliseconds, 310 milliseconds. So the PPI is equivalent to the tachycardia cycle length. We have concealed fusion. This is what this is called, concealed fusion. If concealed fusion, PPI equals tachycardia cycle length, we are most likely dealing with a macro reentry. And not only that, we are also in the critical corridor, the critical isthmus of the tachycardia. Another measurement, another relationship to think about here is the stim to atrial electrogram versus electrogram, local electrogram to another reference electrogram. So for example, so stim to A versus EGM to A. This is exactly what we do in VT when we entrain VTs. You know, stim to KRS versus EGM to KRS. Well, how do we know that we're actually not in a side loop, that we're not, you know, just close to the tachycardia site of origin, but not, and not, you know, that we're right in it, not necessarily close to it? We look also at the stim to A. The stim to A, if you looked at the patient site to any reference electrogram, he took this reference electrogram here on the halo, and that interval, that measurement was 135 milliseconds. From the EGM to local electrogram, once the tachycardia came back on the ablation catheter, this is sort of the electrogram that he was capturing when he was pacing, because I don't see it here. Okay, I see ventricular electrograms here, but I don't see this electrogram, which tells me that I captured it. Now, from this to this is your PPI, and from this electrogram to the next reference atrial electrogram was exactly the same. It tells you you are exactly inside the isthmus of the tachycardia. This is a good ablation site. You need to ablate there. Progressive fusion, just to show a quick example of that. If we're dealing with typical flutter, we're just going to do this on typical flutter for the ease of understanding it. We're pacing from the lateral tricuspid annulus. Tachycardia is going. We pace at a cycle length of 220, cycle length of 200s, 190, and 180. And you can see the part of the, you know, the part of the atrium that is activated because of our pacing, which is what we call the antidromic part of the tachycardia. The antidromic limb of activation keeps getting bigger as we pace faster. Why? Essentially, it's almost like you get up early in the morning and you make it to work. If you get up earlier, you're going to make it to work. You know, instead of making it to work just like everyone else at 8 o'clock in the morning, well, you get up 20 minutes earlier. You're going to get there 20 minutes before everyone else. You get up an hour earlier. You're going to get there an hour earlier before everyone else. So if we pace faster, that means we're pacing earlier. We're getting earlier and earlier and earlier. So we have more atrial tissue to capture before the tachycardia comes back. And that's why that zone of fusion moves as we pace faster. And that means that the activation on the halo catheter also changes based on how early we paced. So, for example, you can see, first of all, you can see that there's manifest fusion. Why? Because I'm pacing. This is what the crista catheter activation or tricuspid annular activation looks like with pacing and tachycardia. They're not the same. See that pattern versus that pattern. They're not the same. Subtleties matter here. Okay? They're not the same. So that's called manifest fusion. I'm able to get manifest fusion and also make it progressive. Okay? It goes from this to this to this to this. These are things that prove that we have fusion. We did not terminate the tachycardia. Okay, we did all this while the tachycardia was ongoing. We do not have to be in the critical isthmus of the tachycardia to prove that it is micro reentry. We need to be in the critical isthmus of the tachycardia to figure out where to ablate. But we can prove the mechanism of the tachycardia by pacing in anywhere in the atrium and show in either concealed fusion, which you have to be in the isthmus to show concealed fusion. If you're away from that, you have to show progressive manifest fusion. And if you can fuse and reset, then it is a macro reentry. What comes first? What comes back first? We're pacing during tachycardia. And you can see we're pacing right in the middle of the activation on the halo catheter, on the tricuspid annulus. What does that mean? We're fused. You see that? The pacing spike is in the middle of the P wave. See it? That is fusion. Same thing for VT. If you are able to accelerate a tachycardia by pacing right in the middle of the QRS, you are fused. This is reentry. You cannot do this with a focal rhythm. Okay, you cannot influence a focal rhythm by pacing in the middle of the P wave. And so we are pacing. The activation looks the same, whether we are in tachycardia or not. So this is called, we have concealed fusion because we did not change atrial activation while we were pacing. So that tells us we're close or in the isthmus of the tachycardia. But as we are pacing here on the tricuspid annulus, these atrial electrograms here are coming back at the pacing cycle length. This is the last entrained part of the tricuspid annulus. This is the last entrained part of the coronary sinus. If you looked at it, you would think these are all tied together. But no, the coronary sinus comes back at the tachycardia cycle length, not the pacing cycle length. And so this is part of the next beat. Why is that important? The part of the atrium that comes back at the tachycardia cycle length is part of the orthodromic circuit, the orthodromic part of the circuit. Okay, that's closer to the critical isthmus of the tachycardia. So you can get that sort of dissociation between those two. When you have slow conduction, you can actually create patterns that look like that. But you gotta be able to tell what comes back at the tachycardia cycle length. This is a clue. You need to understand that. So that part of the tricuspid annulus. Sorry, I said that's the corner. This is the coronary sinus, and so that part comes back first at the tachycardia cycle length. It is more relevant to what we're talking about. It's more relevant and closer to the tachycardia isthmus than this part, which was captured antidrum. Okay. Other findings during entrainment we do not want to miss. You can see tachycardia ongoing. This is a very complex electrogram, so bear with me a little bit. So we have tachycardia ongoing. We pace here, this probably doesn't capture. We're pacing at 300 milliseconds. This probably doesn't capture. And then we have a stimulus that goes down, and it essentially at a shorter cycle length. I think it's this one here. This one goes down and actually terminates the tachycardia. Now, it terminates the tachycardia because we know the coronary sinus right there, it stopped. This is how we know that this stimulus is the one that terminated the tachycardia. This one brought the tachycardia in a little bit earlier. So that entrained this electrogram. So tachycardia was going at 330. This stimulus goes down, brings this next electrogram a little sooner. This one terminates the tachycardia. Why did this terminate the tachycardia? Although it actually did not give us another P wave, it did not give us another set of coronary sinus electrograms, and it happened right in the middle of the P wave. You see the P wave right there, and you see the coronary sinus right there. That stimulus fell when the coronary sinus was committed. Half of the atrium was committed. Okay? So how could a stimulus that doesn't propagate, doesn't capture anything that we can see either intracardiac or on the surface, how can it terminate a tachycardia? It has to be in the critical isthmus. It essentially creates a wavefront that then collides with the wavefront of the tachycardia and causes the tachycardia to terminate. This is called termination with a non-propagated stimulus. It is very important. If you see that, ablate right there. That is diagnostic for being at the site of origin of the tachycardia. This is true for VT, same thing. So anytime you pace and you terminate a tachycardia, go back and look. That might be all you need to see that day. The post-pacing interval, we said it needs to be equal to tachycardia cycle length. Within 30 milliseconds is very acceptable, at least for typical atrial flutter. Sometimes the overdrive pacing can actually give you a longer PPI, and it doesn't necessarily mean that you're far away or that you're in a bad location. How can that happen? Well, sick tissue, scar tissue, as you pace it faster, can actually conduct slower. So as you pace faster, you can cause slow conduction in part of the circuit. And what that does is it prolongs your post-pacing interval. It looks like you're not in the right spot. You are in the right spot. So that happens in atrial flutter. It happens when the cycle length is longer. It happens when you're dealing with a lot of scar and when you have a lot of decremental conduction. So pitfalls of intravenous mapping. Now, sometimes you get a situation where the post-pacing interval is actually shorter than the tachycardia cycle length. And that is very confusing. Well, how can that happen? Well, either you're dealing with a rhythm that is not even re-entry. So when you start playing with a focal rhythm and overdrive pacing it, you can get all sorts of things that make no sense. And so that is a possibility. Another possibility is that you're measuring your PPI to a far field electrogram. So you're essentially measuring a shorter PPI. So try to figure out your near field electrogram. Try to look at what you paced and what you captured before and what was not present on the electrogram when you were pacing and what is present now, and kind of do that subtraction in your head. You could also be dealing with an unstable reentry, so multiple exits or multiple isthmuses, and with pacing, you're actually selecting an isthmus that has slightly faster conduction. That's possible. Or that the tachycardia itself keeps switching cycle lengths on you, which is a situation where you should not be doing entrainment mapping in the first place. It's not going to be very helpful if the tachycardia cycle length is variable. And that is true for VT, true for any form of SVT, true for atrial tachycardia, atrial flutters, all the same. Or you could be doing high output pacing. So if you have virtual electrode, if you up the output on your stimulator, you are going to capture a whole lot more tissue. So you're essentially measuring return to a spot that is far away from where you're the tip of your catheter is, and so you could get a shorter PPI. When you get that, just pause a little bit, think, bring your output down, try to see if you're dealing with an automatic rhythm versus re-entry. How do you do that? Remember, we try to deliver a stimulus right in the middle of the P wave, bring it in a little closer, see if you can reset the tachycardia. Essentially, what you're looking for is you brought one tachycardia beat earlier, and then the next one comes back at the tachycardia cycle end. Okay? There's no compensatory pause. There's no compensation for the tachycardia cycle. It came back right away at 300 milliseconds. You brought one at 250, and then or at 270, and the next one came back at 300, which is the tachycardia cycle end. That's resetting. So go back and think through it, see what is going on, and why you're getting misleading data. How do you approach it? If you wanted to have sort of a stepwise approach, what do you do first? If you're dealing with an atrial flutter, you're trying to figure out what to do. You start working, pacing first at the HRA, the high right atrium or the lateral right atrium. And if that is in, great. Well, okay, let's stay in the right atrium. We're going to pace at the proximal coronary sinus, and if that is in, then we're dealing with typical flutter. If the lateral RA is in, but the coronary sinus is not in, well, guess what? Then we're limited, we're localized to the lateral surface of the RA. This is somebody that has either an ASD, that had right atrial pathology of some sort, COPD, they have right atrial scar, they had an incisional scar, they had prior ablation, something like that involving the lateral RA. And we showed what that P wave would look like. Now, we pasted the lateral RA, and if that is not in, then we move on to, well, move on to the next step, which would be the proximal coronary sinus. Proximal coronary sinus is in. Well, okay, well, that cannot be typical flutter because remember the lateral surface of the RA is not in. So that takes us a little bit closer now to what? To the left atrium. So the proximal coronary sinus is in. Well, check the distal coronary sinus. Distal coronary sinus is in. That's going to be mitral flutter at that point, or mitral annular tachycardia. And then, well, okay, well, what if that is not in? Then it could be something that is in the left atrium, could be septal, could be right pulmonary veins, but it is, we know it's not necessarily involving the CTI or the lateral RA. You probably want to map it in the left atrium. What if the high right atrium is not in, proximal coronary sinus is not in, then we're probably dealing with something coming from the left pulmonary veins, okay? That immediately takes you away from that. Well, it could be a roof, depending on flutter, it could be something involving the lesions that are on the left pulmonary veins that the patient had prior PVI, it could be posterior wall dependent, it could be all of that. So this is just a quick thing, and you can literally, you're pacing lateral RA, proximal coronary sinus, distal coronary sinus. Those three, okay, tell you where you need to start. Now, I don't do that. And the reason I don't do that, I don't start with intraimate mapping. A lot of times you have a tachycardia, you really don't want to terminate it, you don't want to change it, that type of thing. I think if you are in a situation where you have a redo, you tried to ablate it before and you could not make it go away or it came back, and you just know that however you mapped it before was not helpful, you could start with intraimate mapping. But just remember, when you do intraimate mapping, you could terminate the tachycardia, you could alter the tachycardia, and that tachycardia that the patient has been in for weeks, waiting for that procedure to cure him out of this thing. As soon as they got on the table, you changed it to a different rhythm, and now you have to take care of that different rhythm first, and then go back and reinduce that rhythm, which if you can't induce it, you have no idea if you got rid of it, or it's just not inducible because you're now under general anesthesia and all of that stuff. It just depends. If you're going to do it up front, make sure that you do not do asynchronous pacing. You have to synchronize your pacing and have proper sensing on the channel that you're going to entrain from. So if you're doing this from the, a halo catheter, if you're doing it from a CS catheter, make sure you change your sensing, make sure you're sensing properly. And so what you do not want is the first stimulus to come in. Let's say the tachycardia cycle length is, just to give an example, 250. You're going to pace at 220. You're trying to overdrive it. Now, you don't want, if you're not synchronized, the first stimulus could come in at 150 milliseconds because you're not synchronized. You synchronize to the QRS, for example. I see people do that. It's wrong. You got to synchronize to the channel that you're going to be pacing from. This is what you need to do. Okay, just like when in VT, you got to synchronize to the QRS. And so don't do intraimate mapping with asynchronous pacing because you're very likely to terminate a tachycardia. Specific syndromes, things that are worthy of noting. Mitral flutter revolves around the mitral annulus. The CS activation can be eccentric, concentric, depending on it being clockwise or counterclockwise. How do you fix it? Well, you need to do a mitral isthmus line that blocks the mitral isthmus, and that you could use a lateral line. We're going to show some examples of that. A lateral line, which essentially requires ablation in the coronary sinus. A lot of people do it and not ablate in the coronary sinus, and it doesn't work very well. The durability of the block there is a lot lower if you do not ablate in the coronary sinus opposite that line. You could also do an anterior line that comes from the superior aspect of the mitral annulus towards the right superior pulmonary vein or the roof. In my mind, instead of saying, I'm going to make a line that goes through this, a line that goes through that, do you think SCAR cares? SCAR doesn't care, okay? If you leave SCAR behind, it's going to give you more problems. So you might not actually have something that spins around the mitral annulus, but you might have something that just, forms micro reentry within SCAR. And so the right approach, which, I recommend reading that paper, the right approach, and I was doing that, for very long before that paper came out. It makes sense, right? If a rhythm is dependent on an area of SCAR, you ablate that area of SCAR, so modify your line to go through it. Well, how do you tell? Well, you can look at your voltage, and we're going to see a case to demonstrate that. Before we get to that, I want to show just the anatomy of that so we don't miss highlighting that part. Where can I demonstrate that a little better? Sorry, I didn't make a really good slide for that, but essentially, if you look here, top left, the lateral line would be going from the left inferior pulmonary vein towards the mitral annulus. So this is the left inferior towards the mitral annulus, ablate that area. That area actually does have thick tissue. The coronary sinus is running right there. So you can get through the coronary sinus, address the epicardial part with ablation up here. You're going to be dealing with high impedance. You're going to have to deliver lower power. And remember, you're not too far from the circumflex. People do it. They don't seem to get into much trouble with the circumflex doing it. But it's important. You got to, be careful. You don't want to perforate that type of thing. You got to be, you got to have good hands and be able to get around the mitral annulus, which takes a little bit of practice. But then you're ablating this part of the left atrium, and then you got to have a catheter over that line. So you could have a catheter in the left atrial appendage, and then you can look at the activation of the coronary sinus, and the coronary sinus will have to activate proximal to distal if you have block. If you still have distal to proximal activation, then you still have conduction, and you keep looking for the gap. And the key here is using, having stability, and stability will come from using a steerable sheath. Cannot ablate this without the use of a steerable sheath. I see people do it, and they just keep burning and burning and burning. Patients keep coming back for redos. And so we will show again more examples of what SCAR looks like and whatnot in this setting of mitral isthmus flutter. As we are talking about mapping, this is another concept I want to throw out there. We're going to show more examples of this. You can have a focal rhythm, and a focal rhythm will look like macro reentry. We talked about that. If you are close to a previous line of block, if you make a mitral isthmus line, which is essentially here, that's where they made that line. So that's a good representation between the left inferior pulmonary vein and the mitral annulus. There is a line of block there, and the line is blocked, but yet they have a tachycardia that looks very much, when you do activation mapping, you have the entire tachycardia cycle length. And it looks like you have recurrent mitral isthmus flutter, but you don't. And so what is the clue? The clue is if you try to overdrive pace, you're going to find that post-pacing interval, very long, to be very long if you are pacing on the side of the line where the site of origin is. Whereas if you paced from here, the tachycardia, the post-pacing interval would be very long. So he's given us examples here. Pacing on this side of the line, you get about 90 milliseconds PPI minus tachycardia cycle length. You pace here, you get 180 milliseconds PPI minus tachycardia cycle length. The activation looks like mitral isthmus flutter. You have essentially the entire cycle length represented, but the reason is the tachycardia focuses here. It encounters a line of block here. It has to go all around the mitral annulus to get to the line of block. It looks like we have reentry, but we don't. If this were reentry and I were to pace here, I would get something that is within 30 milliseconds of the tachycardia cycle length as far as the PPI minus the tachycardia cycle length. And so, that is very helpful. Getting these long numbers in and of itself tells you this is not mitral flutter, but the activation, when you look at the earliest activation in the atrium, the earliest activation is around that side of the line. So these are pitfalls. I have another example to show later. It might be a little bit better. Another concept, also after treating mitral isthmus flutter, another problem you could encounter is now re-entry involving the epicardial aspect of the lateral mitral isthmus, which is why I told you need to ablate the epicardial aspect of the lateral mitral isthmus. This is all incomplete ablation. It comes back. We give it a fancy name and we say it's arising from the ligament of Marshall, but essentially it is just because of incomplete ablation the first time. You cannot do this line and not ablate in the coronary sinus. I cannot stress it enough. I don't prefer that line. I don't do it. I think the recurrence rate with this approach is higher, but what we're looking at here, atrial tachycardia or atrial flutter recurrent after ablation of the mitral isthmus, and you can see early activation here. This is the coronary sinus, and the coronary sinus is showing distal to proximal activation, but it also shows, and these are not ventricular electrograms, they're well splayed out away from the QRS, which is right here, and they do precede the near field electrograms we see in the coronary sinus, the epicardial activation. And you can see that epicardial activation sort of has an inflection point towards the proximal aspect of the coronary sinus with the epicardial and the endocardial activation meet. So the earliest epicardial activation here is towards the distal part of the coronary sinus, and that denotes that you have re-entry that involves essentially the epicardial part, that line. It goes right back into the left atrium, spins around the mitral annulus, and comes right back. There is a very nice paper that was in Heart Rhythm just in the past month or so, just taken this to extreme elaboration on that particular syndrome. And it's, sort of helpful to recognize the different patterns of that. It is very simple. The principle is if you make a line, you got to finish it. You got to get the endocardial and epicardial aspects of the tachycardia. I'm sorry, I'm just going to check real quick the WhatsApp, make sure you guys can still hear me, and okay, good. I keep getting error messages from WebEx. Anyway, please let me know if you don't hear. Roof-dependent flutters. And roof-dependent flutters require some form of slow conduction involving the roof, and also some path that is protected by an anatomic barrier like the veins. So they can spin around the right veins or the left veins, changes the POA morphology a little bit, but essentially they need some slow conduction on the roof. A lot of times you actually see scar on the roof or on the posterior wall, and you can get any pattern in the coronary sinus. It depends which side of veins they're spinning on. Left veins, right veins changes the CS activation. If you have a mitral isthmus line, lateral or septal line, they can also change the activation. And a lot of times when you look at the coronary sinus, what I see typical and what tells me I'm dealing with roof flutter, not necessarily every roof flutter looks like that, but when I see that pattern, when I see the activation in the coronary sinus sort of, earliest in the middle of the coronary sinus, which is what you can see down here, as you go down to the coronary sinus, you see those wavefronts splitting. So essentially the distal coronary sinus and the proximal coronary sinus are on the same timing, whereas the middle of the coronary sinus is early. That is going to be either posterior wall or roof. It's not always like that, but when you see that, you get a suspect roof dependent re-entry. These patients have a lot of scar, and that's just the gist. This is what you guys need to understand: either man-made scar or natural scar. The problem is that presence of scar spells trouble. Once you have left atrial scar, your arrhythmia-free survival is not great. It's not like patients have healthy atrium and just have pulmonary vein triggers. These patients have other triggers arising from reentry. And so, as you can see here, this study was actually, I think it was presented at HRS, and this passed HRS, and it was just published in Nature Medicine, I believe. And they essentially took a large number of patients, and they, did long-term follow-up, looking at arrhythmia-free survival and a lot of other things related to cardiovascular morbidity, stroke, death, and whatnot between these groups, the ones that had small voltage abnormalities, which they defined as less than 20 square centimeters, and extensive ones more than 20 square centimeters. In my mind, honestly, both are extensive. And they found some really interesting differences between these groups, but essentially the group with the once you have voltage abnormalities, if you do not address those voltage abnormalities with additional ablation, you probably have a higher rate of recurrence. The problem is this did not reach statistical significance, but you could tell that in the second ablation group, which is essentially the group that got pulmonary vein isolation and additional ablation targeting the scar, the outcomes were sort of similar. Whereas in the PVI, in the group that didn't have that didn't have voltage abnormality, the outcomes were sort of not that different. And so what we're looking at here is essentially additional ablation of scar improves arrhythmia-free survival. It did not reach statistical significance, but there was numerical signal, and that essentially just means that the sample size was not enough to show the difference. Again, just showing it in a different way. If you had no voltage abnormality, this is your arrhythmia-free survival. If you had voltage abnormality, then if you had mild voltage abnormality, if you had severe voltage abnormality, you saw increasingly worse arrhythmia-free survival. All right, I wanted to show you a case just to try to tie some of these principles together. This is a case I did a very long time ago, maybe 10 years ago. It was with arrhythmia, and at that time, it was pretty, it was crazy when this first came out. The amount of points you could take and the high density mapping, the near field electrograms that Orion catheter gave you were very educational because you could see things you couldn't see otherwise, or you couldn't otherwise see. And so this is somebody that actually had atrial flutter. They never had a pulmonary vein isolation. They had typical flutter, and he had 3 ablations for typical flutter. When I saw him, I didn't think this was typical flutter, and that explained why he keeps having ablations for the same thing and they don't work. So this is right atrial activation. The tachycardia cycle length is 231 milliseconds. And surprise, when we map the right atrium, and I'm going to get to this in a second, but when we map the right atrium, we had the entire tachycardia cycle length in the right atrium, all of it. Now, we talked about that, and we said if we have a line of block, we could see, misleading activation data, because a wave front comes, collides with a line of block, and has to take a different pathway. And this is the line of block. This is the prior CTI line. And the activation has to go around the tricuspid annulus to get to the bottom of the atrium on the lateral side of the block. And so you get something that looks like it's a right atrial flutter. Well, it is not, because when we looked at that CTI, the CTI was dead. This could not be recurrent typical flutter. There is no electrograms. There's nothing on the CTI. So that told us that we were probably dealing with a left atrial flutter, but we could see the entire tachycardia cycle length in the right atrium because they had prior ablation of the cavotricuspid isthmus, and that's probably why he had multiple ablations there. But the arrhythmia was clearly eccentric in the coronary sinus. So it cannot be a typical flutter, really. And, but again, you got to look at all the information you have. So this is distal to proximal activation in the coronary sinus. And so we went on to map the left atrium. Now, we were excited about having arrhythmia, and so we wanted to map this anyway. I'm going to give you two, recommendations. Anytime you have a rhythm that could be coming from the right atrium. So let's say this patient showed up with a concentric activation in the coronary sinus. Let's say the coronary sinus was proximal to distal. And someone told you, hey, no, it is still, typical flutter, it is mitral flutter. I would still map the right atrium first. If your suspicion was this is mitral flutter, I would still map the right atrium first. I'm not talking about somebody that had prior ablation of the right atrium. I would map the right atrium. Now, distal to proximal activation, that cannot be coming from the right atrium. But if you had concentric activation, any arrhythmia, you don't know what it is, map the right atrium first before you go into the left atrium, because you're going to get into the left atrium. You're going to be mapping, you're going to be looking, you're going to be ablating. And then eventually you'll figure out, well, I got to go back to the right atrium, but it will take so long to make that decision and a lot of unnecessary. This is now the left atrium. And this was crazy. I mean, this was like a 55,000 point map in 2013, 2014. That was unheard of at that time. And you could see this spinning around the mitral annulus, and you can see there is a zone of slow conduction right there. This is the zone of slow conduction. Why is there slow conduction in the area? This patient never had ablation in the left atrium before. They never had surgery. Why? Well, a lot of things could be. It could be related to a viral infection. It could be related to an arrhythmogenic cardiomyopathy. It could be related to enlargement of the aortic root causing compression of that part of the left atrium. Just any sort of low-grade myocarditis or type of cardiomyopathy. This area, like we said, doesn't have a whole lot of muscle fibers. And when you start lowering the amplitude, when you start killing a lot of myocytes, this area is going to be denser scarred than the rest of the atrium first because it has a lot less myocytes, right? That's just how I conceptually think about it. I wanted to show you the voltage map here, and you can see the voltage map of this patient. See that scar, and this is exactly why this patient has mitral flutter. The mitral annulus is there to give it a corridor, some protected isthmus, some protected corridor, but the slow conduction comes from this area of scar here. Now, if you were to treat this patient using the lateral line, now look at this figure. This is the left inferior pulmonary vein. This is the mitral annulus. I can connect that line here. I can make a lateral mitral annular line here. You could argue there's some scar here. I would tell you this is just undersampling because of the ostium of the appendage. But if you did that line here, you will stop the mitral isthmus flutter, but you've done nothing to address this scar. This scar will give you then additional other flutters. Now they're going to start looking like proximal to distal activation in the coronary sinus because they will spin that way. They'll spin through scar and go down. So what we ended up doing for this patient, and he had some posterior wall scar too, you can see that here. And so what we ended up doing is we made a line that goes through the region of scar, okay? Because that's the problem. Today in today's today's EP labs, I would have isolated the posterior wall. The patient did well, actually didn't have any other flutters. We did address the roof because of the scar that was evident on the left atrial roof as well. In the PFA world, I would have also isolated this posterior wall. Even if it were RF, I would have isolated the posterior wall because of that voltage abnormality here. We talked about that concept before. I'm sorry, this has taken too long. Another case, mitral flutter. This is a patient that had a prior mitral line. This area here where there are no electrograms essentially is dead. This is scar. This is scar. Big gap in the middle of that mitral isthmus line. Having re-entry around the mitral annulus. And again, where's the zone of slow conduction? You can see it here. This is where conduction slows down. What does the scar look like? Here, this part of the line was durable. This part was durable. There is a gap in the middle, and you can see activation going through it. One application here, rhythm terminates right away. Sometimes the scar is not absolute. See, ablate here, and then the tachycardia length changes, and you start getting wet fronts going through this because it's not absolute scar. So you got to do that line again. If you're going to make lines in the atrium, you have to prove block, and block is bidirectional. You pace on both sides of the line, and you look at the activation on the other side. And you want to scan the line, make sure there is not slow conduction on the other side of it. If you don't have the time or willing to do that, don't draw lines in the atrium and give people problems they don't have. Again, just demonstrating the same thing. We are probably way over what time today, but I thought the subject was just too big and there's no way to address it without talking about all of these aspects of mapping and ablation. So I'm going to open it for questions, and thank you for listening.
Thank you, دكتور خالد. مش عارف دكتورة ميرفت معانا ولا ايه؟ دكتورة ميرفت؟
معلش اسفه انا نمت وانا قاعده. معلش انا اسفه يا خالد عشان بس مرهقه.
لا ولا
ربنا معاكم. معلش والله يعني بس والله مستمتعه جدا بس النوم غلبني. انا اسفه. طيب.
لا يهمك. لو حد عنده أسئلة أو any comments, anything I can address.
Thank you, Dr. Khaled, for this interesting lecture. And I want to ask about arrhythmogenic cardiomyopathy and atypical flutter. Do you have cases?
Yeah, arrhythmogenic cardiomyopathy and atrial flutter. Yeah, so I mean, some arrhythmogenic cardiomyopathy can be atrial, can be ventricular, can be both, right? And we don't think about it too much when we don't see LV dysfunction, but there are syndromes of arrhythmogenic atrial cardiomyopathies. This is really what we see in a lot of those patients. We just don't give it the right name. And so this patient here, that's an example. Look at the pattern scar. And so we see a lot of these patients. I will show you another one. I'm sorry. You know what? I actually do have another example and I would like to show also. Hold on.
It was after AF ablation and atrial myopathy or arrhythmogenic cardiomyopathy without AF?
Without AF ablation. So that one that I'm showing you there, this is idiopathic. I'm going to show you another one that is also idiopathic.
Okay.
I'll show you another one that is also idiopathic. We also just did a few days ago. I'm sorry, I actually meant to put that in there, but I did not. Hold on. I actually can find it. And it's even more extensive than this. And
yes.
So let's see.
And did you go straight for ablation in arrhythmogenic cardiomyopathy and atrial flutter, or we try medical treatment first?
Yeah, so a lot of times, I mean, these patients are usually sent to me after somebody has tried and failed antiarrhythmic drugs. I don't. By the time patients come to me, they've already been. They're usually patients been seen by another electrophysiologist, or and have been and have been sort of attempted that way before. So usually by the time they get to me, it's an ablation. I'm trying to remember the date I got this because I can go back and tell you. I actually do have the maps, and they were actually very very impressive. I'll find them. I might just have to text it to you guys later. But essentially, it was very similar to this, but we had to also isolate a really good chunk of the anterior surface of the left atrium. Man, I'm getting really upset with myself now because I forgot to get this. And there was also scar here in the below the left inferior pulmonary vein, right here, in this area. The patient had a lot of mitral regurgitation. And MR jet sometimes can cause scar here. I see this in you know, not infrequently. I see it in those patients a lot. And so you can't leave large parts of scar unaddressed. He also had some scar along the left atrial septum. These are all things that need to be addressed and not necessarily easy ablations. I think it was done on that day, the 17th. Let me see if I can find my text messages from the 17th, which was, I think, Tuesday. Okay.
So the concept, if we do lines, we do bidirectional block after that.
You have to.
That's the concept.
If you're going to be making lines, you have to block them.
Okay.
Yeah, if you're going to be making lines, you have to block them. You can't. Yeah, here it is. I found the pictures actually. Let me see if I can. If I can show them to you, I can.
Okay, and you did mention another case with the perforation in the unprotected area of the left atrium.
Yeah.
So how
yeah.
did it happen?
I don't. It was an
Ablation
atrial
anterior
ablation.
wall or posterior?
No, it was right on the. No, the unprotected area is right here. So if you were to look at this on a voltage map, it's right here. This area right here. This area right here, right behind the non-coronary cusp. Okay. Buckman's bundle is sort of like right here, and it's right in front of it, right anterior to it. And that area, you just have to be very careful with your power, careful with your contact force. This was pre contact force era, so we didn't have contact force sensing catheters at that time. And I believe, I'm pretty sure contact force was too high. Not necessarily like crazy high, but in older patients, that stuff can be really easy to do. It doesn't take much to actually cause perforation if you are delivering RF with high power, like 40 watts. So you can't have 25 grams of force, especially with an SF catheter. Now, a lot of people don't use SF catheters, but anymore. But you know, Q dot is probably a little better. Let me see if I can actually bring these slides back here. I'll take any questions in the meantime. I can answer any questions while I'm.
Thank you so much. Thank you so much for this effort. Thank you.
Yeah, absolutely.
Dr. I have one question in the chat. He is asking about your approach in anticoagulation in atrial tachycardia. And also, you can mention us for atrial flush.
So if you have someone with typical flutter, usually I ablate the typical flutter. I give them a monitor for a period of time after ablation, 15 days, 30 days, whatever you can do. And if they have no more atrial arrhythmia, they don't have atrial fibrillation, then you just follow them over a period of time and make sure that they don't develop something else. But you can stop anticoagulation after that period of time. It is not okay to do that for atypical flutter. So atypical flutters, I'm talking about left atrial flutters, for example. You know, once you have those, you know, it's essentially an AF syndrome. It just has not become AF yet. So in my mind, those are the same thing. So I would treat that exactly like you would an AF ablation, exactly the same thing. You are not going to stop anticoagulation after an AF ablation just because they have no more AF. You're going to look at your CHADS VASC score, and then you're going to determine based on that if you actually will or will not stop anticoagulation. So that's the approach. Left atrial flutter is exactly like an AF ablation. don't have recurrence, they don't have any other atrial flutter, they don't have atrial fibrillation, then you can stop. And the argument there is this is a curable rhythm. Well, typical flutter is very common atrial fibrillation is very common in patients with typical flutter. It is, and that's why you have to do prolonged surveillance for these patients. But generally speaking, if they just have typical flutter, it's curable. This is the case that we're talking about. I'm sorry, any other, did I answer your question?
Thank you, Khaled. Thank you for the time.
That answered your question, okay.
Thank you.
Okay, so this is the case I was just talking about. And look at this, there's so much voltage abnormalities at baseline. This is a de novo, never touched atrium. This patient had typical flutter ablation before. And, you know, I think what happens is these patients have a reason to have atrium. They have for essentially the easy rhythm to address, which is typical flutter, and take care of it, but that's not the end of the story. So I had to isolate the posterior wall, isolate the veins, isolate that piece of scar that I told you about under the left inferior pulmonary vein. And then also had to address the anterior mitral isthmus. This area is full of scar. This is mitral isthmus flutter waiting to happen. And then, you know, you can't leave all of that scar because in my experience, if you leave it behind, you start getting more problems. Now, I didn't ablate in the coronary sinus. The appendage is not isolated. The appendage is activated just fine. If you ablate under, you know, if you try to do a lateral line also, you might actually isolate the appendage inadvertently or cause very delayed activity of the appendage, which then is risk for thromboembolism and everything else. So these patients have to be anticoagulated religiously. And at the same time, you know, you should consider left atrial appendage closure for them. But I don't do that. And so this was very adequate. You could not put that patient in AF after that lesion set. I believe, yeah. So just two different projections here. You know, that's my approach. I was also going to probably address some of the septum, but then he also had a very aneurysmal septum. So I thought a lot of that voltage is just the function of the aneurysmal septum. You couldn't get good contact force. So anyway, that's the case I was talking to you. So this is idiopathic, never been ablated before. That can happen. Okay. Obviously, if you do any linear ablation lesion set, you have to isolate the left pulmonary. You have to isolate the veins. So this is any left atrial flutter. That is, you know, if you have a focal atrial tachycardia, a healthy atrium. I've had an 18-year-old who had a focal atrial tachycardia that was very incessant, and it was arising from the superior aspect of the mitral annulus, but her atrium was very healthy, and I'm not going to give her a pulmonary vein isolation. It's a focal ablation. We got rid of the tachycardia at the top of the mitral annulus, and that was that. We're done. But generally speaking, if someone is not young and it's not an isolated arrhythmia, especially if it's a macro reentry, okay, any macro reentry in the left atrium, you're going to have to isolate the veins. That's number one. Before you even try to terminate before you do anything, isolate the veins first and then do your linear lesion set. Why? Because you need to connect the linear lesion set to two anatomic barriers. The mitral annulus is one of them, and then the next one is going to be the isolated veins. Or if it's a roof flutter, it's between the two isolated veins. If it is a posterior wall, it is between the two isolated veins and the two isolated veins, roof and the inferior aspect. So lesion sets need to be closed. They need to be closed loose, creating zones of block. Okay, and for that you have to isolate the veins, and then you anchor things to the veins. Other questions?
Any other questions?
I think we have no questions for this very interesting lecture, Dr. Khaled, and this is Dr. Mirvat. Omar Nadam, do we have anything in the chat?
لا خلاص يا دكتورة ميرفت كله خلاص تمام.
Okay. We are recording this lecture, so we can get this recording for the attending. Anytime they can revise it and can send a question to Dr. Khaled. Thank you very much, Dr. Khaled. It's always our pleasure to have you with us, teaching the Board of Electrophysiology, Egyptian Board of Electrophysiology. Thank you very much.
Thank you,
Thank
Dr.
you.
Khaled. Thank you, Dr. Mirva.
Thank you.
Thank you. Do you want me to stay for the additional presentations, Dr. Mervat, or?
لا, I think this is the total time we have. عمر مش كده؟
احنا كده عدينا الساعتين.
Okay, so this
Right,
is the okay.